here in Dallas, Texas. This is kind of the area that I live in, the area I grew up in, the area I was trained in. So Dallas is very near and dear to my heart. It's kind of my local community, and it's where I grew up, and it's where I continue to practice. So with that, today what I'm going to talk about, I'm going to spend the next 20 or 30 minutes or so talking about spinal stenosis and the best ways to treat it, to diagnose it, as well as to hopefully cure it in a way. Now, the whole thing that I'm going to be talking about here is essentially it's tightening of the nerve roots. That's the whole thing that we need to go over. What is spinal stenosis? So in general, if this is a spine, this is your lumbar spine, looking at it from the side, here's the straight on view. It goes bone, disc, and then behind each vertebrae, those are the bones, we have these nerves that come out. And different nerves go to different parts of the body. And there's a lot of overlap. It's almost like a spider web, but there's an overlap of different nerves going to different dermatones. That's the same thing with the neck, going into the arms, going into the shoulders, as well as in the lumbar spine. So you can have different dermatonal patterns. In general, when you hear about people that have butt pain, shooting down the back of the thigh, shooting down the leg, wrapping around the ankle into the foot, that's either the L5 nerve, lumbar 5 nerve, or sacral 1 nerve. So spinal stenosis is just anything that's squeezing the nerves. Essentially, it's anything that's squeezing the center canal of the nerves, or it could be a pinched nerve root on the side. The things that usually cause that are the following things. Disc herniations. You can be living your life, exercising, playing with your kiddos, working out, and then you have a disc herniation that pops out and it hits a nerve root, shoots down the pain. That's extremely successfully treated non-surgically as well as surgically. I'll get to that in just a little bit. The other thing that is more and more common and very common is when you have joint arthritis. These are called the facets. So just like you have an elbow joint or finger joints, you have facet joints, and these are the facet joints in the spine, and those can get wear and tear, just like you get wear and tear of your hip joint or of your knee joint. That wear and tear grows similar pattern, almost like a callus formation on your hand or callus formation on your foot, on your heel. Well, that same type of phenomenon happens in these joints, happen in these facet joints along the side here. When those get extra thick and those start pushing extra tissue into the muscle, causes pain. But specifically, when that facet joint, so here's a joint right here, it starts growing into the canal, starts growing into the nerve, that starts squeezing that area, shooting down pain, numbness, tingling, and the worst case is when you get weakness. Different motor groups go to different, different nerves go to different motor groups. I'm going to take some questions here in a minute. I'll try to get to as many questions as I can, but let's just kind of go over additional diagnosis. So again, spinal stenosis is anything that squeezes these nerves. In general, it's arthritis, wear and tear. And people are like, what is arthritis? Think of arthritis as just any extra tissue, like the callus formation, or you can get bone spurs. Essentially, that's tissue that then hardens. Another cause of spinal stenosis, which much less common, but also very severe and bad, is infection. You can get osteomyelitis after a surgery. You can get osteomyelitis from IV drug use. You can get osteomyelitis from uncontrolled diabetes. So different things that could cause infection that seeds this part of the spine is definitely concerning. And that fluid, that growth, could be squeezing the nerves, squeezing the canal. You can also have a tumor, same argument there, where it's just growth of tissue or bone. It could be a bone growing or cartilage growing tumor that squeezes the nerves. And then you also have this other condition, which is pretty darn common, called anterolisthesis or spondylolisthesis. That's when it goes bone, disc, bone. But you have so much arthritis in the joints here that when they normally are supposed to be moving together kind of as one unit, they inappropriately move. And that inappropriate movement causes the nerves to get pinched in between them. So this one doesn't move that much because there's obviously a metal rod here because it's a model. But if you can imagine this bone sliding forward, it would be dragging that nerve root, shooting down pain. That's one of the most common things I treat as a spine surgeon, is that shooting down pain. The most common condition is spondylolisthesis. Now there's another way you can get spondylolisthesis, and that's when you have a fracture of the pars, something called a pars fracture. And that's shown to somewhat of a degree right here. This bone is all loose. It's not necessarily that fracture that creates the pinching, it's the loss of the stability through the spine. Because now you've lost some of the stability through the spine, all of that motion is actually now going through this disc space. So your disc space wears out at an accelerated rate, and then it becomes some bone-on-bone arthritis maybe, or that starts slipping forward, or it's decreased height and slipping forward. That is a source of back pain, but more commonly from a surgical indication, the things people that get better are those that have the shooting down pain. So a lot of times I'll even try physical therapy, conservative treatment, chiropractic therapy, stretching, and even steroid injections. I don't do the steroid injections myself. I have a pain management doctor I work with, but that's where they can put different combinations along these nerve roots here to calm down the irritation associated with pinched nerves. So with that, let me get to a couple questions, and then I'd love to continue our talk about different ways to diagnose spinal stenosis and to treat spinal stenosis. So one question from Caroline here is, I used to farm. Now I am 70, collapsed disc. Now I find I have lost the feeling my knees down. What is the diagnosis? My goodness. Well, I'm not exactly sure. Really, a way to diagnose it, it could be from the spine. It could be many other things. But from a spine standpoint, if it follows a certain pattern of pain or if you have weakness, probably the first step you want to do is get an x-ray. You want to see the stability of the bones. You want to see the stability and alignment of the spine. Once you get an x-ray, then you should be, if you have certain conditions, such as the ones you presented there, I would definitely recommend a lumbar MRI. So an MRI of your lumbar spine, and that can show where different compressions are. If there's something called cauda equina syndrome, where there's so much compression, but it's usually down here in the lower part, in the cauda equina part of the spine, that causes bowel issues, bladder issues, loss of sensation, loss of sexual function. Those are all common things from a somewhat of a rare condition called cauda equina. I got a question here from Raj, one of my longtime friends here, longtime supporters. So Raj, great hearing from you, my friend Raj, sorry. It says, hi doctor, hope you're good. I found out I have cervical instability due to the ligaments in the upper neck that are overstretched. What do you think about stem cells or regeneration, PRP? Okay, a little bit of a controversial talk, but hear me out. So in terms of PRP and stem cells, at best, from a spine standpoint, they are very strong anti-inflammatory medications, anti-inflammatory treatments. There's not great data that shows that stem cells, and definitely not PRP, regrows the disc space or gives you that disc height back or causes nerves to regenerate. At best, what they do have are anti-inflammatory chemicals in it that, similar to a steroid, calm down the nerve root. Now, if I could pick between PRP or stem cells or a steroid injection, well, for sure I'd pick the first two. But you know, the stem cells and the PRP aren't completely risk-free in terms of taking those out of your body. And as importantly, those aren't free. Not that an epidural shot is free, but now for stem cells, you could be paying that doctor, and spine doctors do it all the time. So just because I'm not doing it doesn't make me the bad guy in a way. There's spine doctors that do this for cash money all the time, $5,000, $10,000, $15,000, and they'll take stem cells or PRP and inject it along these nerve roots here. And at best, it's a strong anti-inflammatory. So people do get better, and a similar concept from the steroids, and there's a strong anti-inflammatory component. If there was really good data and high-level journals with high impact factors that are peer-reviewed in the spine literature, what we'd want them to show is that they cause the cells, not in a lab model, but actually in a clinical model with randomized groups and placebos, to show that those patients actually regrew disc height, and that just hasn't been shown in that capacity yet. There's been lab studies that have shown it can differentiate into different cells, and it also can decrease pain. I'm not denying that. You know, you can even have a placebo shot in your knee of steroid or water or nothing, just poking the skin, and that's been shown in a large sample of VA patients. And I always joke, of course, it's the VA that had that study. There's not many other places you can get away with something like that. And that showed that those patients got better just from the placebo effect. So I'm not at all saying that stem cells or PRP has a placebo effect to it. Patients do get better from it, but patients also get better from epidural steroid injections, and those aren't risk-free either. So Raj, kind of going back to your initial question, do I recommend stem cells or PRP to help you with your neck pain or neck issues? Of course. You know, if you have tons of extra cash lying around and that's what you want to use it on, great. Epidural steroids have a great track record also. Really, the number one thing you need to do is get a great diagnosis. Once you have the diagnosis, you can really start to treat it. Going to David here, I have a healed fracture. Will it show that it's healed? A CT scan could help indicate if it's healed, but also an MRI would help show if you have a healed fracture. And the thing you're looking for on an MRI are bone marrow edema, and that pretty much is swelling along the bone. If you have like a pars fracture in the back, usually this is more in the teens, late teens, they can get a pars fracture from hyperextension injuries. And if that's found and an MRI shows that it's a newer fracture with those bone marrow changes, that's when patients have a pretty good outcome by bracing them, trying to immobilize them, shut them down from sports. There's different time periods, whether that's 3 months, 6 months, or 9 months. But hopefully there's a great track record with that. From Brandon, great question coming in. The implant called TOPS to stabilize the facet joints, normal range of motion. So TOPS is a pretty interesting thing. The thing I just kind of tell patients about it is it's still a pretty darn major spine surgery. It's still a big incision in the back, and you're still getting 4 screws into your spine. And instead of having a rod connecting them, you have this kind of a rod that connects to a ball that connects to a rod that connects to a screw, if I kind of said that somewhat in a way that makes sense. And it's almost like a shock absorber between those 2 rods. So no, it's not a fusion. It does help keep some of the range of motion of your spine. I am not 100% against it. It's something where if one of my colleagues was doing that procedure, I probably wouldn't make too much fun of them publicly, but I'm not willing to experiment on my patients. And maybe that makes me a late adopter on a certain future technology, but there's many technologies out there that were motion sparing that we thought were great, and then kind of turns out maybe they weren't so good. Like the Coflex procedure is kind of in that category, but at least with the Coflex, it's very low morbidity. It's a small incision, it's a small implant, it's not doing too much harm in a way. Whereas the TOPS, you still get these screws in your body just like this. You still have 4 of them, and it makes subsequent surgeries, if you need a fusion later, kind of tough because you're losing some of that fusion mass. You're losing that joint there that normally you kind of rely on to have the fusion bed. So you really have to rely on either the interbody to fuse, but now you're going through kind of a lot of scar tissue, unless you live in a community where they do a lot of anterior surgery, or you rely on the posterior lateral fusion there, which is our true and tried traditional way. And so we have a lot of good ways of doing that. But you also have to have the open surgery now to get those screws out. So kind of a complex answer. I know it didn't 100% answer it for you. If you find someone out there doing it, great. I'd love to see if that's insurance approved. You're probably paying cash only at this point in 2023. Maybe not in some of the FDA studies. They pay it for you. I just don't know the answer. So again, I'm just all about not having people misuse their funds, kind of looking for a miracle treatment out there, because sometimes when a patient thinks they pay cash for something, they think they're getting a better product. Such as if you fly across seas to get a certain procedure and you're paying cash. Well, just because someone here in the States takes your insurance doesn't mean it's a lesser surgery. Sometimes paying cash isn't a better way to do it. From Raj, my good friend, you're asking me about diet to stop degeneration of disc disease. It's a little outside of my scope. I'm not really sure, my friend. Just from kind of what I've read online, but not in a true research fashion. I hear that anti-inflammatory diets are great, but I don't do any of them myself, and I don't have any personal experience with it and haven't really researched it much myself. So I would just kind of defer those questions to someone else. Another question coming in from Anthony: what's your thoughts on endoscopic facet denervation? Not a procedure I specifically do, but I'm in favor of it. Essentially what that is, for those at home that are listening, so an endoscopic facet denervation, from what I'm understanding you're asking. Let's kind of back up. So the facets are these joints in the back here. They can cause pain. They can cause some wear and tear pain. That wear and tear pain can hurt. That hurts your back. So one treatment we have the pain doctors do, is they can do epidural steroid injections in these facets here, hopefully to get you better, but also to diagnose the issue. And if you get a little better from that and then it comes back, well, at least you know that's your issue. So once you've done that twice, that kind of proves that's your issue. Then you could be a candidate for something called a medial branch block, and that's kind of a denervation type surgery where there's nerves. They're not shown here because this is a spine model, but there's nerves kind of around this joint here, and then you can kind of burn these nerves, not these. These are the really important ones, but these smaller sensation nerves in the joints, and that's what the denervation is, or a similar to a radio frequency ablation or a medial branch block. So endoscopically is just a fancier way. I don't necessarily know if it's better or worse than the traditional way with X-ray. I'm not really arguing that either way because I don't do either of them. But endoscopic is putting a camera in there and then burning those nerves. So my thoughts on it are favorable. I don't do any myself. The only guy I know that does them, that's a buddy of mine, is a guy in Vail at the Stedman Clinic, Michael Galeazzi. He is Galeazzi, sorry. There's a Galeazzi fracture. I always say that. But he's great. He does that procedure specifically. He's at Stedman in Vail, so ask for him. Another person here, Tony. I had surgery with Dr. D. Recovering, looking forward to full recovery. Appreciate all the comments. That's great. Another one here, Mary Fitz, ablation versus fentanyl patch for spinal stimulator for debilitating pain. Oh my God. Well, those are pretty serious things. Well, look, I'll tell you right now, I really hate fentanyl patches. I don't like prescribing them. I think they've been prescribed kind of under my name maybe once or twice. And when I found out that the patient got that, I say absolutely no way. Get that patch off them. No way. So I personally hate fentanyl patches. I think they should only be allowed for cancer patients. I'm not saying your pain isn't real or isn't significant, but I just have a very personal hate with fentanyl patches. In terms of spinal stimulators, I have mixed thoughts on spinal stimulators. So here are my thoughts as a spine surgeon about spinal cord stimulators. In general, they're good for patients that either have neck pain or back pain without a perfect identifiable cause, or for patients that are not good surgical candidates for chronic neck pain or chronic back pain. In general, if someone's having shooting down pain, down the butt, down the leg, down the thigh, and they have an MRI that shows they have spinal stenosis, so squeezing of all the nerves, or a pinched nerve, they probably shouldn't do a spinal cord stimulator. Instead, they might need something called a laminectomy, a microdiscectomy, a disc replacement, a foraminotomy, many other types of surgeries to take the pressure off that nerve. That could be a treatment option for the shooting down pain. A spinal cord stimulator isn't typically the best choice for that shooting down pain because usually that means there's a pinched nerve, and so there's probably a lesser procedure or a different type of procedure that's more indicated for the for the shooting down pain. So again, spine surgery is best for patients that have shooting down pain, numbness and tingling, weakness either in the arm or in the leg or in the thigh. Patients with chronic neck pain, chronic back pain, spine surgery is not always best for them. Those are the patients that might instead benefit from a spinal cord stimulator. So a little bit of a confusing picture, a little bit of a confusing argument, but in general, I'd say if you have the shooting down pain, I wouldn't start with the spinal cord stimulator. I would start with this, seeing 1, 2, maybe even 3 spine surgeons to see if there's a different cause for that pain. So spinal cord stimulators are okay. I don't do them, not from a personal standpoint. I do spine surgeries. Not that a spinal cord stimulator isn't a spine surgery, but I have pain management doctors I work with that do that. Just reading a couple more things. From PJK, it's an interesting name you have because that actually means proximal junction kyphosis. So not 100% your question, but let me get to what that is. So PJK, or proximal junction kyphosis, is when you have a spine fusion, usually in the lumbar spine, that's multiple levels, and the level above it starts to wear out. Proximal means above. Junction is usually at the junction of a fused versus non-fused level, and kyphosis is when it starts to collapse down, kind of collapse forward. If the curvature back in the spine is called lordosis, kyphosis is when it collapses down forward. This is most commonly seen in patients that have something called a T10, which is up here, all the way down to pelvis fusion. And this level up here at T9, T10 starts to wear away, and your body unfortunately starts to collapse forward. In 2023 and 2024, spine surgeons are doing a much better job of understanding something called pelvic parameters. That's when we measure where the hip joint is, the sacrum, and kind of put all these measurements in to see what your alignment is. Our goal is essentially to bring your shoulders, so your shoulders over your hip joint, to have you have a balanced spine. When you get a big fusion, that's one of our #1 goals, is to leave you in appropriate alignment to limit the rate of proximal junction kyphosis. But it's a big challenge. If you search other videos out there, you'll see hours and hours and days of debate of how do we reduce that rate of proximal junction kyphosis. There's so many things we're doing, include tethering, cementing, different rod constructs, different screw constructs. But at the end of the day, it really starts with the surgeon's understanding of pelvic parameters. That's getting x-rays that include the hip joint. So that way on the side lateral views, you can see as the patient have a flat back, and then when you fuse them up here, it's going to be just a solid rock and it collapses forward. Or are you putting in cages in the disc space? Are you shaving off the bones back here to realign the spine backwards to give them this lordosis? Those are ways we try to limit the rate of proximal junction kyphosis, but it's a major problem in spine surgery. It's something that we have many great leaders in the field of spine surgery that are really pioneering the technology and the ways to limit that rate of spine complications. Those are usually later complications, 3 months out, 6 months out, 2 years out, could be even 5 years out. But sometimes once you get to 5 years out, it's maybe other factors that have started to contribute to it. So to get to your question specifically, even though you did not ask about that at all, but it's a very interesting topic, you asked about ultrasonic spine surgery. Well, let me kind of be clear about that definition. So what I'm talking about today is spinal stenosis. And that's when you're looking down the canal and you have all these pinched nerves. What the ultrasonic tool does, it's similar to many of the other tools out there. It just has a little bit of a different variation. So I don't want to misrepresent how it works. Essentially what we're doing now before the ultrasonic stuff, I was trying to see if I had any other tools kind of show it. But it's kind of like a burr where it's a handpiece, and at the end of it is a ball with spikes on it, and it spins, and you burr out the bone. You burr out the bone. And that's a great tool. I still use it on many surgeries, but it has a little bit of some benefits, but also risk. Some of the benefits are it's a little faster. It kind of really pulverizes that bone, and that's maybe good if you want more wide open area. And it's just more common. It's more familiar. Surgeons grew up using that technology, and it's been around forever. The ultrasonic technology is a tad different. It actually has a blade that, you know, if I run it on my skin really hard, I'm sure I could cut myself, but you kind of push on things, move things around. It's kind of like this. This is sharp in a way, but not that sharp. That's kind of how the blade is on the ultrasonic technology. But what it starts to do is it vibrates, it oscillates, it has these micro particulates in it that I don't totally understand the technology, but it helps vibrate that at such a high frequency that they've matched it to the modulus of bone to where it essentially melts the bone away. And it helps cut an area of the bone, cut an area of the bone. And that's just a way you kind of open up that area of the bone. I like it. I didn't like it at first. I mean, it really was a learning curve. It makes a really annoying noise, a very high-pitched frequency. But once you are married for long enough or have enough small children, you lose all hearing of high-pitched frequency anyway. So I'm good there. And then the other thing is it adds a lot of water to the wound. And some people don't like that. But the counter argument is that it decreases the rate of infection because you're essentially irrigating the wound, the surgery throughout. So that's one of the benefits of the ultrasonic technology also. It's somewhat widely available. Any hospital could get it. Any surgeon could use it. It's just another barrier is it's expensive. It adds another, it just varies, another $500 to $1,500 to $2,000 to the case, depending on what that hospital's contract is. And so I get it. You know, if some surgeon is an owner in a surgery center and, you know, that's maybe $1,000 is, you know, 10% of what that whole surgery is going to be costing. And they still have to pay the staff, they still have to pay the anesthesia, they still have to pay all this other stuff. So it really just eats into maybe it's the profit margin. I'm not really sure if that's an argument or not, but you know, I always kind of wonder why don't more surgeons do it? And I kind of chalk it up to one, there's a learning curve. If you've learned how to do something your whole way and you're good with it, why would you want to go learn a new way? Fair. It's expensive. Again, it doesn't come out of my pocket in a way. That's kind of the hospital's problem, I jokingly say. And it makes a really annoying noise. Kind of once you get past those things, that's when I find the benefit from the ultrasonic technology. I'm going to do a couple more questions and then I do have to go. But again, our whole topic today is there a cure for spinal stenosis? And so in terms of if there's like a magic bullet or a pill cure for spinal stenosis, their answer is, of course not. But are there surgeries? Yes. Are there non-surgical options? Yes. And it kind of depends on what your symptoms are. From a non-surgical option, there's multiple studies that show that physical therapy, chiropractic therapy, even acupuncture and medications and anti-inflammatories are all cures for spinal stenosis. It's going to help take away the effects of it. You might still have the pinched area there, but the symptoms of leg weakness, the symptoms of endurance issues, the symptoms of numbness and tingling running down the legs, those can get better without surgery. A lot of it's based on time and taking away the inflammation aspect associated with it. Once you've failed those things, once you've tried those and you still have it, or once you have just severe pain and you can't go through that, or you have weakness in your legs, or you have cauda equina syndrome, things that just can't wait, yes, there's surgical options. Those might be something called a laminectomy, an ultrasonic decompression, an endoscopic decompression. Those could be things such as disc replacements, and those also could be things such as fusions. Now, fusions get a really bad reputation, but they really shouldn't. The reason they have a bad reputation is, one, if people got one and they did bad, well, they're probably going to tell a million people. Whereas if they got one and they did good, they're not going to be broadcasting it. Two, I'm the problem. I'm out here telling everyone how great disc replacements are. This is a disc replacement. It's a model of one. And I like disc replacements. But don't get me wrong. There's many indications for disc replacements, and there's many better indications for a fusion. So while I like disc replacements, I still like fusions a lot. I think when a patient is indicated for a fusion and they've met all the criteria and they get a fusion, they're going to do fantastic. The patients that do best from fusions are, in general, patients with significant spondylolisthesis, patients with significant back pain, but also the shooting down radicular pain when it's a 1-level fusion, a 2-level fusion, or patients that have severe degenerative scoliosis or adolescent idiopathic scoliosis. Those are patients that really could have life-changing in a beneficial way from a fusion procedure. Patients that maybe don't do as good with it are those that aren't surgically optimized. That could be your weight. Having a body mass index over 35 is not great. Patients that are smokers, patients that have chronic health issues, patients that have chronic pain management issues. Those are all people that you could still operate on. I'm not saying that necessarily, but really the surgeon needs to be very specific, and they kind of need to somewhat cherry pick their patients so that they're doing best for their patients. The other thing is chronic neck pain or chronic back pain. If that's the main issue, you really need to work it up. You got to prove to both the patient as well as to yourself that that is the pain generator. You could have an awful looking spine, and if you just do a fusion of 1 level, the patient's still probably going to have a lot of pain because the rest of their spine hurt. So that's why I say it's best to do surgery when you have the shooting down pain, shooting down numbness and tingling, because those are some of the more clear definitions of who one needs surgery, or based on certain pathologies, who needs a fusion versus not a fusion. So is there a cure for spinal stenosis? Yes, but it kind of depends on that level. To fix the whole spine, you would need to fuse every single level and do a laminectomy of every single level. Then that would kind of prevent spinal stenosis at all those levels in the future. But that's kind of a ridiculous argument. You don't really need that necessarily. If you have 1 level that's severely tight, something called neurogenic claudication, that is a form of spinal stenosis. Fixing that level, opening it up, might cure that for then. If you don't do a fusion, you still could get additional joint arthritis in the future and subsequently need a surgery in the future. Or you can get disc collapse. That would cause a pinched nerve, not necessarily spinal stenosis, but there's just a lot of different definitions. So I just want to make sure I'm very clear on that. Kind of reading some other questions here. Someone asked to show a pedicle screw. This is a pedicle screw. So it goes into the bone. So if you're looking down the canal, it kind of goes into the bone. Let me see. Kind of just like that right there. I mean, pretend there's a bone here. I wouldn't put it into the disc space, but it kind of goes in this thing called a pedicle. This is a pedicle right here. So if you're looking at the side of a spine, I'll show you right here. So this is a pedicle screw. When you do a fusion, the pedicle screw will go through the pedicle right here on the side of the bone, and you'll send it with a trajectory that gets a lot of purchase and keeps the tulip above the bone. You then connect multiple tulips together, and that creates a spinal fusion. Spinal fusions are best indicated when there is anterior listhesis, when one bone's slipping on the other, or if you have to correct alignment issues, deformity issues, scoliosis issues. That's when a spinal fusion is most indicated, and a pedicle screw means you're getting a spinal fusion. This is a special cage here. This is called a lateral cage. So it goes in under the ribs, kind of like this. And you can kind of see how there's a wedge shape to it. This one, not sure how many degrees this is. This looks like maybe 12 degrees. Can't tell just looking at it. This might be like a 12-degree cage where once I put it in, it's an expandable technology. One of the technologies I love a lot that are really, really increasing, especially the last couple of years, are expandables. So you put a cage in flat. If I had a wrench here, I could close it down. But I put this cage in flat, and then with another tool, I can kind of twist it, turn it, and it opens up, gives you more height, as well as curves back, gives you more lordosis, that good curvature of the spine. So that's what This cage is here. It's a lateral cage. It has this wedge shape. So if I put this in this way, it's going to help. If the spine's normally flat and straight like that, it's going to help give you the height back and curve back the spine. That's a really important part about spine surgery. Those are lordotic cages. That's pretty much how every cage is built these days. It could be totally neutral, but in general, it's lordotic. It wants to curve you back. I can talk about another concept of spine surgery kind of before we go, and those are disc replacement. This is a disc replacement right here. This is a cervical disc replacement. So I'm a big fan of cervical disc replacements. And if you look at it right here, this is kind of how it looks, where it's moving, it's motion. Let me see if I can open it up. If it opens up, I don't want to drop this one out. It has this, oh, there it goes. I knew I was gonna knock that out. So it has this end plate here. It goes on top and it works just like that, where that is a cervical disc replacement. You have enough weight on top of it and it's, it's a nice snug fit to where it doesn't fall out. They don't dislocate, and there's kind of different ways on different disc replacements where they help prevent that. Could it happen? For sure. I've never heard of it happening. Surprisingly, you'd think it would happen more often, but it's pretty darn rare, and it has to be maybe an extremely significant trauma, like a car wreck or almost a decapitation related event that would pop out that disc replacement thing. The same thing could happen in fusions that haven't healed, where they have the cage in there as well. So again, this is the lumbar spine. Looking at it from the side, it goes bone, disc, bone, disc. Behind each bone is something called a pedicle. So this column of bone right here is the pedicle. When you get a fusion, that's where the screw goes. It goes through that pedicle. Above it and below it are the nerve roots. Different nerve roots go to different parts of the spine. In general, we say like the L4 nerve goes on the side of the thigh. It could be the front of the thigh. The L3 is more front of the thigh. The L5 is more kind of back of the thigh. And then it goes down the leg, can wrap around the side of the leg, and then on the top part of the foot is a classic L5. So if you get a disc herniation, if you get severe disc collapse, if you get severe joint arthritis and hits the lumbar 5 root, that's what causes the shooting down pain down the thigh, down the leg, and over the foot. There's many non-surgical treatment options such as anti-inflammatories, Medrol dose pack, steroids, injections, chiropractic therapy, physical therapy, weight loss therapy. Those are great non-surgical treatment options if they're under the right guidance. From a surgical standpoint, your surgeries are pretty much in the following categories. You could have something called a decompression, which is either a laminectomy, which shaves off this whole area, a foraminotomy, that's getting into this tunnel and opening it up. You could have a facetectomy, where you take this facet off, but if you do that, then you need to do a fusion. You can't just take a facet off. Or you have different fusion procedures. You can have an A-lift. That's where we go through the belly, great surgery, and open this area up. Again, is the most powerful surgery we do because it gives you the most disc height restoration, gives you the most lordosis restoration. You can get something called a T-lift. That's where we go from the back. Let's see if I have a T-lift cage here. I do. You could get a T-lift surgery. That's where the small cage goes in from the back and it goes into the disc space to open up that area, to restore your lordosis. You can also get a lateral surgeries for sure from L1 down to L4. At L4-5, it just depends on your hip crest if you can get to that area. You can get an O-lift. An O-lift is oblique lumbar interbody fusion, and that's where it's a cage kind of like this, and from the side, so it's not through the belly, not under the ribs, it's kind of in between the two. It's obliquely inserted. That's a very unique surgery. One of the benefits of an O-lift is that you can still get a big cage in, but you don't have to necessarily go through the belly. It's not a ton different, but don't have to go through the belly. You more go from the side, and you can access L5S1. So in general, there's just a lot of different spine surgeries out there. There's a lot of different ways to fix something. There's a lot of different techniques. Not all fusions are the same. Some are 1-level fusions. Some are 8-level fusions. Some are a fusion with a laminectomy. Some are minimally invasive. Some are open. Some are augmented reality. Some are robotic. There's just so many different ways out there. So if you are avoiding getting care because you've heard about someone who had a spine surgery and they didn't do great, or they only got 50% better, well, I'm not doubting that's true, but there's just so many different pathologies out there that are treated with different ways. It'd be like saying you had a friend who once had an issue with their car and they brought their car to a shop and it never got much better, so that's why you're not going to go get your car fixed. Well, that's a little ridiculous. You don't know what was going on in their situation. You don't know what car shop surgeon they went to, and you don't know what training or technology they used, and you don't know the state of that car. You don't know if it was driven around for thousands and thousands and thousands of miles and really beat up, and there wasn't a whole lot they could do in the first place. So I usually just tell patients, look, just because you talk to a spine surgeon doesn't mean you're going to get spine surgery. It's always good just to know your options in life, whether that's with um, banking, with housing, with health. Just know your options, and that's kind of the best way that you can get the most accurate treatment and get multiple opinions. Patients sometimes are afraid to tell me that they're going to get a second opinion. I encourage it because I feel like that's going to help me kind of win the day in a way. Like I feel like I do very conservative work. I feel like I'm very ethical, very trustworthy. I'm very friendly, and I give them a lot of time. So when they want to go get a second opinion, I legitimately welcome that because I think it's going to create a more favorable environment for me post-operatively if they end up kind of coming back. So with that said, I just wanted to just jump on here, answer a couple questions about spinal stenosis. I appreciate everyone with the questions that came in. I kind of jump on here maybe once a month or so to answer different questions. I appreciate you sharing this to your peers, to your friends. We do telemedicine appointments all the time. You can go ahead and direct message me on any of my social media platforms, and you'll get an automatic response. Obviously, I'm not going to give any medical advice on there, but I can kind of tell you how to set up a in-person appointment or telemedicine appointment, kind of whatever's best for you, and also based on where you live. So with that, have a great weekend. I look forward to kind of talking with you guys in the future, and thank you so much for subscribing, but more importantly, thank you so much for just taking the time to listen to me. Bye.